Well, in Gloucestershire, early in 2011, we became increasingly aware that although we did well for most children in the early years, the gap between those who did well and those who did less well continued to show us that we needed to make some changes. This was particularly true of those children experiencing chronic neglect due to the parental substance misuse or mental health, but not exclusively that group, and we'll talk some more about that shortly. But what we were aware was that there was a need for change if we were going to impact on that gap, which was very stubborn in terms of our ability to shift it. There were other drivers at play at the time which helped us. For example, there was the national target to increase the numbers of health visitors. There was also a need for us to recommission the way our children's centres operated to develop greater consistency in terms of outcomes and practice. And we also had considerable feedback from parents and practitioners about the services they received during the early years. We also were acutely aware that the pressure on resources that we were all experiencing in local government and in the NHS at that time was just going to continue. So we needed to find smarter ways of working together to achieve good outcomes. So what did we do? Well, first of all, we looked at the convergence of our needs assessment and those other drivers to get support for a more integrated approach to both commissioning and provision in the early years. And that resulted in getting agreement from the PCT, or the Clinical Commissioning Group as it now is, and the County Council. During the process we carried out an extensive consultation with parents and other practitioners in the early years and stakeholders. And that resulted in us developing a joint strategic framework for commissioning in the early years. Sounds grander than it really is, but the important things about it were that we had some agreed outcomes across the agencies, including the commissioning agencies, and also agreement about the priorities of delivering a differentiated approach from universal services through to targeted and much more intensive wraparound support. The process was a key issue here because we were conscious, the two of us and our colleagues, that there was a need to get political will of the agencies, political with a capital and a small p, behind what was quite an important alignment of capacity and resources to pull in the same direction. On the face of it, it appears that that would be an obvious thing to do, but nevertheless, it can be a challenge sometimes aligning the agencies behind the same set of priorities and outcomes. So what we did was we gathered the evidence and the narrative first so that we could make a case, and then we used the existing mechanisms, and we're fortunate in Gloucestershire to have a joint commissioning partnership between the PCT as it was and the CCG now with the County Council, and that gives us a great opportunity to share with the commissioning directors and other members and other key people what it was that we wanted to try and achieve. The other important part of the process was that we took a very measured and long-term approach. So we went to them first to test the water. We were keen to establish whether there was an appetite for us to come back to them with the more detailed proposals, rather than bringing the whole thing to them at once. That seemed a good tactic in the sense that it meant that they were used to the subject in hand, and they knew what to expect when we went with the more detailed proposals. So I think that worked definitely in our favour. We also had to do quite a bit of work in terms of aligning the timetables of the decision-making processes. So although the joint commissioning partnership can indeed provide a lot of weight, the individual decisions of the key funding agencies and commissioners are still separate, and we still needed to align how the council cabinet commissioning process would make a decision alongside that of the PCT as it was at the time. So what does this mean in practice? Well, as I said earlier, we've got some jointly agreed high-level outcomes between the commissioners and the providers, along with jointly agreed priorities. that leads to some shared expectations between the agencies. So if you look at the health visiting service, for example, and the children's centres, they have a clearer understanding about the unique contribution that each makes, but also what each can contribute to the work of the other. And that's increasingly important. If you look, for example, at Ofsted inspections of children's centres at the moment, a lot of the outcomes they expect children's centres to deliver against are indeed health outcomes. And so it's important that we are understanding how the different sectors, agencies, groups of practitioners, the workforce as a whole contribute to achieving those. In practical terms, we reflected those priorities and outcomes in the service specifications. So these things weren't jointly commissioned in the sense that pooled resources took place. It was more about aligning how the services were to deliver their particular contribution. So if you were to look at the specifications for health visiting, children's centres and midwifery, you will see commonality between them in terms of what they're trying to achieve and how that fits with those other services. The other thing we did was to develop an overarching specification under which all of those things fit, so that there's a considerable read across. Then we used a contracting process to also help develop greater parental involvement in delivery of services from children's centres, and that was particularly based on feedback we were getting from parents. Now, of course, the key question here is, so what? We've got some clear benefits showing in terms of organisational arrangements. We have a lot of co-location now of health visitors in the children's centres. That's led also to improved information sharing around individual children and families, and also at a locality level, which gives us as commissioners a great deal of support in terms of how we might target our capacity. We've also got greater clarity between the services and agencies about what each of them do, so that they understand each other better. And part of the key thing, which my colleague Helen will talk about, is the new intensive support team, or turnaround for children's service as it's known, or TACS, for those children who are experiencing the greatest chronic neglect. More of that to follow. But in terms of, so we've got some organisational impact. In terms of impact for children, whilst we can't necessarily attribute all of this to the changes we've made, the indications early on are good. There are more children receiving the early education offer who are eligible. We have parent champions in children's centres supporting more vulnerable children as a result of the parent-led approach we've taken. Most children are achieving a good level of development by school entry. There are more parenting programmes taking place through health visiting and children's centres, and parent engagement with parenting courses has also increased. We've also got more children who have a child protection plan or looked after accessing early education. We've got more young children who are fully immunised by the time they enter school, and that's greater than the national average. We've also got increased numbers of teenage parents and pregnant teenagers engaging with support, and more vulnerable children and families are being identified between health visitors and children's centres. So in general, there is good indication that things are working. So there is more to do, but we feel that the overall review of the impact is positive. We are carrying out more specific evaluations, and we're reconsidering the model in the light of pressure on resources. In terms of the specifics, we think we're definitely going in the right direction.